be presenting an overview of ischemic CVA. I've chosen this topic as it is a leading cause of death and disability in Australia, and up to 1 in 6 people will be affected by stroke in their lifetimes. Today I will be talking about the pathophysiology, the symptoms to look for, the diagnosis and the treatments that are currently available. Ischemic stroke can be defined as any vascular injury that reduces cerebral blood flow to an area of the brain, causing neurological impairment. This decrease in blood flow can be from a few causes. It can be from an overall decrease in cerebral blood perfusion. It can be embolic or it can be thrombotic in nature from things like atherosclerosis or dissection, anything really that activates the coagulation cascade. When the coagulation cascade is activated, exposed collagen fibres promote platelet aggregation. Prothrombin is activated to form thrombin, which converts fibrinogen to fibrin, which meshes with the platelets to complete the thrombus formation and either partially or completely occlude distal blood flow, resulting in that ischemic injury. Cerebral blood flow is normally around 40 to 60 mils per 100 grams per minute. Once this drops to 6 to 10 mils is when infarction occurs and that area of tissue is irreversibly damaged. When cerebral perfusion stays around the 20 mil mark, this is called the ischemic penumbra, which comprises tissue that is structurally intact, however functionally impaired. This area is vitally important as the tissue is still salvageable for a window of time, and it's also where a lot of our symptoms will manifest from. So the common neurological symptoms that develop in ischemic stroke include altered level of consciousness, confusion, motor and sensory deficits. One of the tools used to identify stroke is the FAST acronym, which looks for facial drooping, motor deficits in the arms, slurred speech or inappropriate speech, and the time since the onset of symptoms. Another tool that can be used is the cranial nerves assessment, which focuses more on looking at what area in the brain is being affected by that ischemia by getting the patient to perform a series of small tasks. While these tools can be useful in giving us an indication that the patient is suffering from a CVA, the only true diagnosis is by CT scan, and this also confirms whether the stroke is hemorrhagic or ischemic in nature to guide treatment. The current gold standard for treatment of ischemic stroke is thrombolysis. The most commonly used agents are alteplase and urokinase, which work by converting plasmogen to active plasmin, which breaks apart the fibrin mesh within the clot and allows the body to clear the fibrin degradation products to restore that perfusion to the ischemic area. Time is extremely important when it comes to fibrinolysis. If you can get the patient to that definitive treatment within a 3-hour window, you've got a 1 in 4 up to a 1 in 9 chance of a good outcome from fibrinolysis. After this time, the ischemic penumbra is becoming increasingly infarcted and the risks with thrombolysis will outweigh the benefits. And then this is when the focus shifts from that acute treatment to long-term rehabilitation treatment to try and reduce any impact of lasting disability. Thanks for listening.